What's going on, people? It's your boy DJ A-Ron alongside my brother as always. And today's show is very special because I don't know if he decided he wanted to be a pallbearer today or if he's a coach, football coach or basketball coach. I'm not sure, but Antonio is dressed up today.
Hey, all business for our guest today, man. I got to make sure we represent,
I love
First impressions mean a lot, So.
Definitely. This is the A Square podcast, back at it with another one, and we have some very special guests on here with us. Antonio, would you like to lead us out, brother?
Absolutely. Make sure y'all like and subscribe to the channel first and foremost. www.asquarepodcast.com. We are back with another interview, and of course, when we love bringing our fellow doctors on, and then you know who comes with that, Brett. That's always, right. Man. So, yep. Brett, welcome back for the A Square podcast, man.
Hey guys, thanks for having me back. It's been a while.
Yeah,
it's been a little bit.
Well, thanks for having us back on today. Today, I have with me Dr. Glasgow from Atlanta Gynecological Oncology. And she's going to come on and join us today to talk a little bit about cervical cancer and ovarian cancer. And for me, it's an important topic because, as you guys know, I lost my mom last year to ovarian. So bringing up the awareness and making sure there's more education provided for everyone out there, for all topics. But for me, this one just hits home.
Yeah,
so
absolutely.
Happy for you guys to have us, and hopefully we can bring some more fun and education.
Absolutely. And just to let you guys know, if the screen at any time looks like you're frozen or somebody else is frozen or anything, don't worry. It is uploading as we go. So we're good. Don't stress. Don't worry about it. We're good.
So before you introduce Dr. Glasgow, we got a surprise for both of you guys.
We do.
You don't even know this. You ready?
What?
You ready?
Right,
so
here we go.
This episode marks our 40th interview.
That's right.
With the A Square podcast. So I want to do something for y'all. Let me put on this hat real quick.
40.
I love it. Hey, that's special.
So we appreciate it.
The thing is that we've had on, of course, obviously we've had on doctors, we've had on attorneys, we've had on professional athletes, Olympians, like
pilots,
we've had on so many,
chefs,
pilots, you name it. We pretty much had everybody on here, and but it definitely is an honor to continue this work with you guys and continuing to spread awareness as well. So thank you, and it's 44. It's 44th and counting. We're gonna keep it going.
Hey, I'm glad it's us. I'm excited. This is great.
Yeah,
absolutely.
So, Brett, do you want to introduce our guest?
So just reintroducing real quick. Again, this is Dr. Michelle Glasgow from Atlanta Gynecological Oncology. She works with us here at Northside Hospital, and I'm just happy she's able to join us today. I met her last year when we had a community engagement, and she's just amazing, easy to talk to, and very, very demanded out of our patients. Like, everyone just wants to see her.
Good.
So it's great.
Good. Welcome, Ms. Glasgow.
So, Dr. Glasgow, I'll turn it over to you and the guys.
Thank you for inviting me to speak with you today. I'm excited for this podcast.
Absolutely.
No problem. Our first question that we ask everybody is, do you mind introducing yourself? Tell us a little bit about you, where you grew up, what got you in this field, what you like doing, anything you want to let the listeners know.
Okay. So I am from New Jersey originally. I did most of my training in the Northeast. I was in Rhode Island for college, medical school at Brown University, and then at Yale for my residency training. And then I did 2 fellowships, first at Emory and then at the University of Minnesota. What brought me into GYN oncology was very personal. My father was a general OB/GYN, solo practitioner. He practiced in the Bronx, and he always told me that OB/GYN was the absolute best field in medicine in the whole world. I didn't want to believe him, but he was true. He was correct. My father always knows best.
Yeah.
And then, so when I was in medical school, as well as college, my interest in women's health grew, but it was largely because of his influence and seeing seeing just how devoted he was to his patients and the conditions he treated, as well as how special a relationship he had. But then my grandmother had lymphoma, and then sort of seeing her experience with her cancer, which my family, even though they never really clearly stated what it was. But then once I realized what it was and what she was experiencing, that drove my interest in oncology. And ultimately in medical school, through different rotations, I realized that GYN oncology was really the best fit for me, just in terms of being able to care for women and to empower women as well in the different conditions which they experience sort of across their lifespan. But then also in terms of treating patients with cancer, because it is the most unique honor to treat patients, as well as really to become not just part of their treatment team, but also in a way like their family, as well as with their families, to treat them in their experiences with cancer and along their treatment journey. When I am not at work, what I love to do more than anything in this whole world is to spend time with my husband and my 2 daughters.
Nice.
It's because of my husband that I'm here in Georgia. I met him when I was at Emory, and we've been married for almost 7 years, and we have a 4.5-year-old. She talks about her 5th birthday every single day, even though it's not till June. And then we have a 2-year-old who is just growing way too quickly for me. So
Yeah,
I love it.
so that's sort of my life. That's my everything.
You know, you brought up something that I've had so many conversations with people about this before, and how difficult it can be when you have a parent that's in a field and then you follow in those footsteps. I've seen a lot of tragic stories about people trying to do that and it not really working out. One, he must be really proud of you. That's number one. But were there any trials and tribulations with that? You know, how did that work out?
So I will tell you that the reason I didn't want to follow in his footsteps is because he was a solo practitioner in general, OBGYN. They're not that common anymore. And essentially, he took 2 weeks off a year.
Oh, wow.
He would work all the time. He would drive across the George Washington Bridge several times a day to check on his patients, because we lived in northern Jersey, but his practice was in the Bronx. And his work was his life. And even when he retired, that's actually when I started to go through residency. And then fellowship training. He would ask me questions and quiz me on everything and tell me his opinions. But I wanted to have a better balance in life than I thought he did in his profession. So that's sort of, I think, one of the bigger reasons why I wanted to avoid this field. But it's really the absolute best thing. I will laugh because, we'll make a joke out of it because I think that the same devotion that he had towards his patients, for example, we would be on vacation and he would call, he knew the labor floor number by heart.
Oh, wow.
Yeah, and so he would call the labor floor, even if we were in a country that was 6 hours ahead, just to check on his patients, even though he had a friend who was covering for him. And yeah, I sort of do that too. I'm even when I'm not here physically, I am here physically most of the time. when I'm not here physically, I'm still just kind of just checking in with my patients. My office staff knows that. If I'm out of town, they can still call me. They can still call me. They can still send me a message, just because I'm always here for my patients.
It's like shutting it off is it's like you want to shut it off, but you can't. You don't want to shut it off, actually.
Yeah. I will say though, I think that I really do when I am with my family. I'm with my family though. I'll shut it off until the girls go to bed.
There you
and then
go.
I turn it back on. I'll turn on my computer at 10 o'clock. But when I'm with them, that's something that I've had to learn to do over the years too. But when I'm with them, my time is with them.
Well,
Absolutely.
we apologizing to your patients because we stealing time away from them. You know what I'm saying? So we appreciate you coming on the podcast. One thing I would like to know with GY Oncology is there an age limit or group when I guess females need to start looking for this? Because like we just heard, Brett lost his mom obviously to this. But is there, let's say when females turn 14, 12, 20, 30, is there any age group where they should really start checking into this?
So, excuse me. That is actually an excellent question. What I will say is that I'll take a step back and just talk about the ages of women whom I treat.
Okay.
I primarily treat women in their 30s, 40s, 50s, 60s, 70s, 80s, up to 90s even. I have had younger patients who are in their, teenage years. What I will say is that I treat, just to take a step back, cervical cancer, ovarian cancer, uterine cancer, vulvar cancer, which is cancer of the labia, the outside of the vagina, also vaginal cancer. But patients are also referred to see me who may not have cancer, but rather a precancer, or who may have a complicated surgical history, and they may be referred to me for more complex surgeries.
Okay.
In terms of screening, because I think your question also addresses screening.
It does.
Right.
Unfortunately, for all of the gynecologic cancers, actually, except cervical cancer, there isn't a good screening test out there. And especially and Brett could probably speak to this too with his experience with his mom. Ovarian cancer, unfortunately, at this point in time, there isn't a good way to catch it in an early stage. The only cancer that we can reliably screen for and either catch before it becomes cancer or at an early stage in the cancer where it has not spread beyond the starting organ of origin is cervical cancer. The Pap smear, which is a screening test for cervical cancer. And it's recommended that women start having Pap smears performed at the age of 21.
And that's yearly?
So that's a good question.
Okay.
There are different organizations out there which have produced different guidelines.
Okay.
On the frequency of when you should have Pap smears, as well as sort of even what to do for abnormal Pap smears. And what I will also say is the Pap smear, there are two different parts to that test. One part of it is this, what we call the cytology, which is an examination of how the cells look under the microscope. And then the second part is the HPV testing, which is a test for the HPV virus, which is an extraordinarily common virus. It is a sexually transmitted virus. It is responsible for most cases of cervical cancer. So for patients, I will also say that in the past, it was recommended that women have Pap smears every year. That is no longer the case. For women who are under the age of 30, so between 21 and 30, if your Pap smears are normal, it's recommended that you just have the Pap smear alone, with the cytology specifically, every 3 years. And then if the test is abnormal, then you have the HPV testing performed.
Okay.
For women who are over the age of 30, there are more recommendations out there. You can have the Pap smear with the cytology plus the HPV testing every 3 to 5 years, if it continues to be normal. That's what we call co-testing, when you do both at the same time. There are some out there who will also, recommendations out there where you can just do primary HPV testing alone. And then, of course, that frequency changes if the test is abnormal and you require follow-up testing. So that's sort of cervical cancer screening in a nutshell. It's recommended at this time that if a woman has normal Pap smears, she can stop having routine pap smear screening after the age of 65.
After 65.
Also, if a woman has had a hysterectomy, she's had removal of her uterus and cervix, and hasn't had any significant abnormal pap smears, and the hysterectomy is performed for a benign condition, like, for example, fibroids or bleeding related to fibroids, she can stop having pap smears performed. So that's cervical cancer. One more thing I'll add in terms of cervical cancer is there's a vaccine available to help prevent it. And I think that is just so unique because the only cancer out there that could be preventable with the vaccine is potentially like liver cancer related to hepatitis B. But otherwise, cervical cancer is so unique. And I hope that in the future we'll see the rates go down. And I think we're already starting to see that somewhat because of the vaccine, which it's really being targeted towards children starting at age 9 to hopefully target them before they're exposed to the HPV virus. But it has since been, I think 2018, it's been since approved for adults up until the age of 45.
So it's relatively new then.
The HPV vaccine has actually been out probably since the mid-2000s.
Oh, okay.
Maybe like 2006.
Okay, gotcha.
Somewhere between 2005, 2006 is I think when it first came out. And there have been multiple changes to the vaccine over the years. There are more than 150 actually forms of the HPV virus. And the vaccine will generally won't cover all of them, but the most high-risk ones, as well as the lower-risk ones, HPV 6 and 11, which are responsible for genital warts.
Gotcha.
So that is sort of, I'd say, when women should really start to think about at least screening for cervical cancer. There is no good screening test for ovarian cancer, or uterine cancer, or vulvar cancer, or vaginal cancer. What I could tell you a little bit, if you like, about sort of how those cancers present, but what I really tell women at all times is you really have to be aware of what's normal for you and what's not normal. And if you feel that there's something that's ongoing, that's not normal, and that's persistent. So, for example, with ovarian cancer, the most common presentation is bloating, constipation, changes in bowel movements, sometimes nausea, getting full really early, and oftentimes these symptoms can be mistaken for other conditions. So, by other providers, either by a primary care doctor or an ER doctor. For example, they may think that a patient is constipated or gaining weight. And you have to have a suspicion that there's something else ongoing and that the patient should have like a CT scan. And unfortunately, by the time the patients have a scan done, as well as by the time the patients start to show these symptoms of ovarian cancer, it is spread.
Yeah.
So I always tell women you have to have, just to really be aware of something, if something in your body is changing. And also to advocate for yourselves, because you may see a doctor who sort of brushes you off, unfortunately.
Right.
But if you have a feeling inside yourself that something is wrong, don't feel bad or feel guilty to get a second opinion. I always tell my patients if they're not comfortable with something, even if they're not comfortable with something that I recommend, there is nothing wrong with getting another opinion on your condition. And the physician you're seeing shouldn't feel bad about that either, because you're really just trying to advocate for yourself and to make sure that nothing is being done.
Sorry, Dr. Lasser. I was going to jump in real quick and say that is exactly what we experienced with my mother. What Dr. Glasgow described is exactly what we saw happening. And unfortunately, my mom was the kind of individual who liked to contain a lot of her medical, happenings to herself. She didn't want to bother other people with what was going on with her. So by the time we knew something was going on, because she had been experiencing the bloating, the abdominal pain, and everything, the change in bowel movements for a little bit. But when she really expressed how painful it was, by that time, when we got her to see somebody, and again, it had to be caught by a CT scan. It had already spread to the point where there was not much that we could really do for her, unfortunately. And that's why I say that it's personal to me for ovarian and cervical, because it had spread to the point where the doctors weren't sure where it originated, either ovarian or cervical. But if I just want to let listeners know, if you yourself have doubts about it, if you know someone that you've seen, similar symptoms, don't be afraid to ask questions about it, and talk to somebody about it, because, like Dr. Glasgow said, ovarian cancer is very sneaky and very hard to detect. It is the 5th leading cause of cancer-related deaths in women. So, just what Dr. Glasgow says, what we say out to our community all the time when we're engaging our community. You just have to know your body, and if something persists that's strange for your body, talk to your physician about it. And if they rebuff you, talk to another physician about it.
Yeah.
So,
and I think that's I'm really glad that you guys are speaking on, having a second opinion, having, the courage to do that. Cause I think that's one of my biggest regrets when it comes to, my mother's passing, was that I just took everything that the one doctor was saying. And even though I wanted to speak to somebody else just to get, have peace of mind, I didn't do that because I didn't know how to do that. That's the first thing. And, but to hear you guys say, hey, it's perfectly okay and it should be encouraged, I feel like our listeners will really, appreciate that.
It's really okay. And I'll just speak personally. If I have a patient who has a question, or isn't satisfied or wants more or just another opinion, I encourage it. And what I'll say to patients is, you may be a little afraid to ask for another opinion, but I wouldn't be. And you can ask that doctor, who else would you recommend? Because we'll give you other names. Unfortunately, GYN oncologists, there are not a lot of us. So in the Atlanta community, I know all of them almost, like in all the major hospital systems. So I'll easily give patients a list. But I will also say, if you get a lot of resistance, that is a red flag. But you should just speak up for yourself, because a lot of times you may get a second opinion and hear the same thing. Right. But it will give you, I think, some peace of mind and comfort.
Well, I think it's great to hear you say, if somebody asks for a second opinion, you wouldn't be offended. I think that's where the nervousness came from me, was that I felt like this is a professional and I don't want to offend this person. So I can appreciate that.
Yeah.
I would like to ask, since these cancers are in the reproductive area, right? I think this is a big issue are any of them stopping females from having kids? If they do, or when they do, get over this cancer, right? They're survivors. Can they have kids after? And can you get pregnant while you're doing, you know what I'm saying? So, all these things that could happen or potential, right? So I would love to hear kind of different scenarios of what you've seen, what you studied, or, I know you busy today. I don't know what happened today. So just let our listeners know. Yeah. I'm trying to help them out,
So that is a really good and important question. As I mentioned, I see women of all ages, and I do see a lot of women who are in their 20s, 30s, 40s. And either have a diagnosis of pre-cancer or cancer where the treatments, I'll say the standard treatments, would impact their fertility. What I will say is, there is generally always a fertility sparing option for the earlier stage cancers. I'll say that as a very general statement, and each patient, each cancer is a little bit individualized ultimately.
Right.
So, for example, with cervical cancer, the standard treatment is usually radical hysterectomy or a combination of chemotherapy or radiation. Which treatment is recommended really depends on the stage, as well as the extent of the cancer, either in the cervix or beyond the cervix. But for patients who are very early stage, they may be either candidates for a conionization procedure, which is removal of a large part of the cervix, or trachelectomy, which is removal of the whole cervix. But with that, they maintain their uterus is left in place and their ovaries, and they could conceive in the future.
Okay.
There are cases, actually, of cervical cancer which are found during pregnancy. And the treatment of that can be more complicated.
Yeah.
But it is something that sometimes can be treated during the pregnancy as well, whether it be with chemotherapy or ultimately surgery towards later in pregnancy. I will say for cases of any gynecologic malignancy, but specifically like cervical cancer or ovarian cancer, which are the ones which would be found really in pregnancy more commonly. That is definitely a very multidisciplinary approach to treatment, where the GYN oncologists work with obstetricians, maternal fetal medicine specialists. So that's just briefly cervical cancer and how it could be treated in a way to preserve fertility. For uterine cancer, I will say that for patients who have a very early stage, those patients may be eligible for hormonal treatment with a progesterone, either a pill or the progesterone intrauterine device, or IUD.
Can I just ask real quick? When you say early, like, can you like specify the differences between catching it when you say early versus a little bit later, just so for our listeners as well?
Oh no, for sure. So I will say early means a little something different in each cancer.
Okay.
Because each cancer has a different system of staging.
Okay, gotcha.
Which describes not only, for example, like in cervical cancer, the staging has a lot to do with the size of the tumor as well as the depth of invasion into the cervix, but then also has it spread to like lymph nodes or other areas in the pelvis. But staging is just a general way of describing, is the cancer where it started, or has it spread somewhere else?
Gotcha.
And where. But each cancer has their own system.
Gotcha.
But for what I'm describing in terms of fertility preservation, these patients have the earliest of early, where it's generally a very small cancer, has not spread.
Gotcha.
Has barely spread into the organ even where it's originating. I will also say that with each cancer, there are also additional pathologic risk factors which we look at in the report. Once that cancer is originally diagnosed, which will also impact our recommendations for treatment and for whether that patient is a candidate for fertility preserving surgery. Fertility preserving treatment, which may not actually come out in the staging. We also use imaging to help determine if a patient is a candidate for fertility preserving treatment. So, for example, for uterine cancer, before making a final recommendation about whether a patient could be a candidate for progesterone treatment, I would order an MRI of the uterus to see if they see any tumor which is growing into like the muscle of the uterus, because that is a sign, that is a reason why that treatment, the progesterone treatment, may not work, as well as a PET scan or a CT scan to evaluate for whether there's any spread to lymph nodes, which would then also indicate a higher stage. And patients who have higher stages, so for example, stage 3, where there's spread to lymph nodes, they're not candidates for hormonal treatment. I'll lastly just talk about ovarian cancer and fertility preservation. Patients who are diagnosed with ovarian cancer, there are different types of ovarian cancers, and not all ovarian cancers are the same. And what distinguishes one type from the other is really how the cells look under the microscope. That also impacts their prognosis and their treatment. But patients with ovarian cancer, many patients are eligible or are able to have children in the future, but again, depending on the stage. So, for example, there's a whole, I'll say, classification of ovarian cancers, which are called germ cell tumors, which are actually tend to be seen in women who are in their teens, or maybe women in their early 20s. And some of these women, they'll have surgery, they'll have one of their ovaries removed, they may even need chemotherapy in the future. But they can conceive in the future.
Okay.
And one last thing I'll say is sometimes women have to undergo chemotherapy during pregnancy, and that is a risk and benefits conversation. And again, a multidisciplinary conversation.
Man.
Right.
Last thing where I'll close on that particular area is that whenever I need a patient, and I think this applies to all G1 oncologists, we'd all say the same. Whenever I need a patient who is the childbearing years and has not completed childbearing, hasn't had children, or wants more children in the future, that is something that we discuss.
Okay.
And we make sure they're aware of all their options, and sometimes it also involves a referral to meet with a fertility specialist as well.
Gotcha.
I got you.
I had another question for you, which is, we call this practice, you call it practice, screenings, so on and so forth. How often is it where you don't have the answer? How often is like that you have to seek, other people to help with, whatever is going on with a patient, you have to go get help with that for you?
Oh, do you mean where I may reach? Well, do you mean where I may work with another specialist?
Right, with another specialist, right. How often does something like that happen?
What I'll say, I'll give it two-part. I see a lot of patients who don't have cancer in my practice.
Okay.
Who either are referred for pre-cancer, which never progresses, to cancer. That's usually a pre-cancer of the cervix or the vagina or the vulva. But I also see patients where they're referred to me for surgery because of some medical complication, or because they've had multiple previous surgeries and this upcoming surgery could be more complicated. But they don't have cancer.
Gotcha.
But they're just sent to me because of the complexity of their case.
Gotcha.
So I'll say that I don't know the exact percentage, but I do feel I see a percent of patients who don't have cancer. What I will also say is G1 oncology is a specialty where we work very closely with other specialties. So for our patients who have cancer, we do work very closely with the radiation oncologists and medical oncologists. I perform surgery and I also administer chemotherapy for my patients who and they'll receive their chemotherapy in the infusion center, not in my office, but I also do work very closely with the medical oncologist. I also work with other specialties, specifically colorectal surgery, urology. I work very closely with them just during different surgical procedures. And then, of course, the general OBGYNs, too.
Gotcha.
I would like to ask What's the process of this, right? So this is for both of you guys, because obviously I know Brett had to deal with it on the other end. So what, from start to finish, where you have a female, doesn't matter the age, but she starts to get bloating, cramps, maybe bleeding, whatever issue it is, and you find out that it is cancer, right? So what are the next steps for this individual who are going through it? And then Brett, if you don't mind talking about kind of what are some of the things that your mom had to go through from the other side, right? Because these people are going to have spouses, kids, parents, whoever, and they might see, okay, well, the next step is they might have to lose their hair or whatever, so they can get mentally prepared for that and understand that it is okay. You know, we're going to get through this. So if you guys can speak on those scenarios.
Maybe I could start briefly on how patients come to see me.
Okay.
Usually patients who present with signs and symptoms of, I'll say, ovarian cancer, they almost never come to see me directly. Usually they're sent to see me either because they went to the ER and then a scan was abnormal and then they were sent to see me. Okay. Or they saw a GI doctor or colorectal surgeon and underwent imaging or colonoscopy and then were sent to see me. Or they saw their general OB/GYN or their primary care doctor and then they were sent to see me. Once I see them, and this applies to every new patient I see, I thoroughly review their history, perform a physical exam. For ovarian cancer, there's a tumor marker, a blood test called the CA-125 level, which can be elevated in many, but not all cases of ovarian cancer. But I will check that for all the patients with either confirmed ovarian cancer or suspicion. Sometimes I'll check additional markers. I'll usually order a PET scan to see exactly where, if and where it's spread. And then based on usually the imaging more so, we'll make a decision on whether they're a candidate for surgery first or chemotherapy. If I don't think they're a surgical candidate, I'll talk to them about getting a biopsy of some sort first. Because you always need that to confirm the type of cancer before starting chemotherapy. So I think that's a quick summary of sort of the process.
Okay.
How they come to see them.
Brett?
So on our end, the process Mom went through is probably a little bit extreme than what most go through. Hers was found extremely late stage. So unfortunately, she was not available for a surgical candidate. Just because of how far it had spread and just because of her age and weight. By the time she got into the, again, it was an ER visit was one of the main things. But because of that, sorry.
Fine. You take your time, Brett, or we don't even have to discuss it. It's up to you, man.
No. I want to because it's important for people to know. But she went through a couple of doses of chemo because that was pretty much the only route that we had at the time. So for my mom, she went through the process of having a port installed on her chest so they could do the chemotherapy. And I will say all the doctors, all the nurses who saw her were fantastic with my sisters and myself being able to explain to us why they were doing what they were doing, And it's funny because my mom's oncologist was actually Dr. Glasgow's partner in Atlanta, Dr. Fuhrer. Dr. Glasgow's up here with me in the Canton, Georgia region, and so my mom lived in the Atlanta region, and so that's what she saw. And it's true, what Dr. Glasgow said earlier, mom's case, just doesn't sit with one physician. A lot of different physicians put their eyes on it and everything, and so we had a lot of information provided to us in that, but there's many hospital visits that we did with my mom, and it was tough. Like I said, it was very late stage. It was very tough to see what she was going through. And unfortunately for us, it kind of boiled down to just time we had left with mom at that point. So we did what we could. We took Dr. Fear's advice on what we could and could not do and everything. And mom made the best of it too. She got second opinions just like we advocated. And, unfortunately, just the information was kind of resolute. It was what it was. But yeah, so that was our experience with it. We went through chemotherapy. We prepared mom, for the hair loss and everything, because that is a part of it once you go through chemotherapy. It's unfortunately our time was just cut so short that we didn't even get to that point with the chemo and everything. So
I'm actually, glad that you said that the doctors talked about what they can and can't do, right? So that's good to know that, hey, these options might be available or might not, but you have to ask, kind of, like what we talked about earlier. Ask those tough questions, and then if they can't, explain it.
Dr. Glasgow, you can correct me, because I haven't been able to engage since pre-COVID, but for Northside, when an oncology case comes, you have your main oncologist, but usually that case is presented to a list of oncologists, and then it's discussed. So is that still how it goes, Dr. Glasgow?
I'll say that not every case is
everyone.
presented.
Okay.
And what Brett is referring to is every Friday we have this meeting called GYN Tumor Conference or Tumor Board. It is the most amazing meeting. I'll say that I've been at many different institutions, and Northside is
nice.
All right, good.
Nice.
it is. It's amazing. It is a meeting of all the GYN oncologists of all 5 Northside hospitals. The radiation oncologist, medical oncologist will also participate. The research team will also participate. Pathologists, radiologists, geneticists, navigation. It's amazing. And essentially, patients' cases that are challenging or not straightforward, because there are patients with GYN cancers which are pretty straightforward, where you know what to do. But if you have, we as a GYN oncologist, treating GYN oncologist, has a question about a case, whether it be on the pathology report and what to do, or the imaging, or the patient's developed a recurrence and you just don't know what the next best step is. This is a forum where you can present your patient and get the input of all the other doctors there. And so not every case is presented, but cases where there's a question.
That's great.
It's simply amazing. And it's also a time to identify if patients are eligible for a clinical trial. There's several clinical trials open at Northside. We're always having separate meetings to review which trials are good to open here. Whether patients should have genetics testing. There are certain scenarios where we already know this patient should have genetic testing, but sometimes the geneticist will hear something about the patient's family history or personal history of other cancers and say this patient should have genetic testing. There's also the nurse navigators who will also potentially identify that this is a patient whom they should reach out to give extra support to.
Gotcha. So to the listeners out there, we have Brett and Michelle Glasgow on from Northside. You ready for the hot seat, man? You can't get out of this, man. You cannot get out of this, Dr. Glasgow. So we need to know, it's a 2-part question. We need to hear a successful, triumphant story. And then we need to hear a story that's like from hell, like that's like one of your worst patients. No names. You don't have to give any indicators, but we need to hear something from you.
And this is not something that we're just, this is something that we talk to every doctor about.
Man.
We always put it out there, and we always get great stories, or at least some type of story.
Yeah.
So, but again, it doesn't have to have no names or anything like that, just your own personal
we ain't trying to get you fired, nothing like that, but we need to hear it.
Not here on the A-Square. And it doesn't have to pertain to this exact hospital or nothing.
Okay, I have a success story.
Okay.
Okay.
I don't know about the other story. But, so a success story. I have a patient. She did not start her initial care with me. She came to see me just for continued follow-up. But she has ovarian cancer. And something that I wanted to mention before is I think it's extraordinarily important that when a patient is diagnosed with any type of cancer, not just GYN cancers, any cancer, that the oncologist be very upfront and just state plain as day what the prognosis is, but then also say, this is what could happen, but this could also happen.
Right.
I think it's really important for the patient as well as the family to hear that up front. And I've sort of been on the patient or family side. As I mentioned, my grandmother had lymphoma, my father-in-law had brain cancer last year, and I've sort of seen both sides. And that can sometimes be hard for oncologists to do because we want to help people. More than anything in the whole world. That's ultimately why we got into our specialty. But it is sometimes also hard to say that we can't cure this cancer. And and sometimes you just have to be very honest about that. I will tell you that for my patients with newly diagnosed ovarian cancer, and I'm sorry, I know I'm being a little chatty.
No,
you're good. You're good.
This is your show. This is your show, actually. We're guests.
But with my patients who have newly diagnosed ovarian cancer, all of my patients, they're always afraid to come in and see me just because I'm an oncologist. But I tell them that this has a bad reputation, this cancer. Like, I acknowledge it up front for two reasons. One is because when it's found, it's usually stage 3 or stage 4. I've only had a handful of cases, and I've been in practice for nearly 7 years here at Northside. I've only had a handful of cases that are stage 1 or stage 2. But the other reason is because I have seen a large percentage of patients, and other GYN oncologists would comment on this as well, enter a complete remission after their initial treatment of chemotherapy and surgery as a combination, but the rates of recurrence of the cancer coming back are very high. But I tell patients that this is a treatable cancer for many, not for all, but for many, it is treatable. And it even when it comes back, and that brings me to my success story. So I have a patient who was diagnosed with a stage 3 ovarian cancer in 2009, and it's 2023. She has been on multiple chemotherapy regimens, but she's still living. She's enjoying her latest granddaughter was born a year ago.
Man,
She was
amazing.
here in my office that day. She couldn't see the baby because of COVID, but she pointed to her across the window from my
Nice.
And she has been on a lot of chemo regimens. She has a little bit of chemo brains. She sometimes forgets things. But she was diagnosed with stage 3 ovarian cancer in 2009. It's 2023.
Amazing.
So I
Wow.
I'm not sharing names, but I do
No,
sort of give that story to my patients as just to give them some hope that it could be them.
Facts.
That could be them. But I also do tell them, and this is like sometimes at the first or second visit, I do tell them that they could also be that visit patient who goes into complete remission, and then 4 months later, the cancer has come back in many, many different places. And I think that it's just important for them to hear that at the get-go. And it's something that we revisit. Because especially that first visit, they don't retain so much. Just because it can be quite
Overwhelming. Yeah.
So that's my success story.
Okay. Appreciate it. My last question
That's all right. You good.
for you. I'm sure there's a listener out there who wants to go into GY.
That's right.
You know what I'm saying? They're listening right now.
Yeah.
And so what are some pitfalls, maybe some advice that you would give them male or female? Is just something that maybe in Ivy League school you wasn't ready for, or, just kind of give them a head start on this path and this journey to be successful?
What I would say are...
You might even be talking to one of your kids right now. You never know.
Yeah.
You know, this episode is not going anywhere. So 10 years down the line, hey, you might be talking to little you.
My daughter, my 4-year-old, is talking about becoming a doctor.
There you go.
See? There you go.
What I will say, I'll give 3 pieces of advice.
Okay.
Number 1, study hard. I was not one of those students in college or medical school who could not study. My husband was one of those. He's also a physician. He could just, I can do that. I had to study. Just study hard. Simply. Study for your tests. Yeah, pay attention. Go to class. Even though I know things have changed since I've been in college, so like everything's virtual. So, the second thing I will say is don't give up. If you have decided that this is what you want to do, don't give up. And I will tell you, and I may get emotional saying this, I think that I wanted, by the time I was maybe like my first year of medical school, which was 2004, that's when I started to really think I want to do GYN oncology. And I started to do everything I could do, research, everything, to prepare myself for GYN oncology. And applying for it. So I was in medical school for 4 years, and then I went to OB/GYN residency for 4 years. So like 7.5 years later, I applied for GYN oncology fellowship. And everyone thought I would get a position. I did not. That was heartbreaking. It was probably like one of the most heartbreaking things ever at that point in my life. Because I'd done so much work towards it, and I thought it was also humbling. And I thought that this wasn't going to happen. And then God brought me to Atlanta.
That's right. There you go.
Yeah. And I did my position at Emory for a year, and I met my husband. And that's like,
look at that.
I'll just say that that was part of God's plan for me.
Yeah.
And then I reapplied.
Nice.
Not many people reapply. But I really wanted this position. I wanted more than anything in this world to be a GYN oncologist. And I got a position in Minnesota.
Wow.
We're extremely happy that you did.
There we go.
And then I went to Minnesota. My husband really wanted me to stay here. But I went to Minnesota. We did a long distance for 3 years. And then I finished my training and came back.
Nice.
But what I would say is if this is something that you want, you're going to have ups and downs along that road, along that path. To your desired profession, but just kind of keep your eyes on the prize and stay focused, and don't give up, and try again if you don't get a position.
Okay.
So
last thing
go ahead. Sorry. Go ahead.
The last thing I will say is that the road to become a physician is a long road, especially if you do a subspecialty like GYN oncology. So just to illustrate, there's 4 years of college, then 4 years of medical school, and then 4 years of residency, and then 3 or 4 years after residency and fellowship. There are some 4-year training programs out there. My husband and I, we use this phrase, delayed gratification.
Yeah.
Because I was in my mid-30s when I got married, and then had my first child at 36 and 39. Sorry, date myself. But what I'm saying is it's a long road, but you get there. You get there, and it's worth it. It's worth it. But it is a long road.
Appreciate that.
You're not alone. There's a huge, amazing community of GYN oncologists out there, as well as just other subspecialists or specialists, depending what area of medicine you go into. And you're not alone. It's doable.
Absolutely. And I was just gonna say, it's gonna be tough for them babies now. You know, they gotta find a doctor. You know what I mean? Like it's just falling like that. Hopefully that works out.
Yeah.
That's
And
cool.
I was going to say, I just want to take the time to say that, I really appreciate the information that you've given on here today. And Brett, of course, we've done this many a times, but the information that you guys provide is opening the doors for all those people that are out there that they just want to hear from doctors, outside of just, going to see your regular doctor. People want to know this information. So I just want to say that we really appreciate it. And thank you.
Thank you.
Problem. No problem. It's been a pleasure. As Brett probably knows, and you can probably see, I love talking about what I do. I love it. I love my job.
We can tell.
Yeah.
We can tell.
And she's easy to talk to about it too. That's the best part.
Yeah.
That's right.
We appreciate it. Is there any way that if our listeners have any questions or concerns or anything, is there a way they can reach you or the hospital that you're at, maybe not you directly?
Yes. I don't know the process, but if anything was sent in, it could be forwarded maybe to my manager who could forward it to me.
Absolutely. People know the website, man, asquaredpodcast.com. You guys can reach us there, and we can forward any information right over to these guys to get you whatever you need. So that's what we got.
Gotcha.
And
Yeah.
anything else, Brett?
No, I was just gonna say I always love coming on here with you guys. I appreciate you guys having us again. And you guys just said we've done this multiple times before in the past, but this one was more personal, and I'm just glad we're here to share the information and the experiences and everything. It almost kind of harks back to our first podcast that we did together about breast cancer.
Breast cancer,
and
yeah.
everything. So, just always, guys, thanks for having me.
Absolutely.
No problem. Can't wait to do the next one. Appreciate it.
Absolutely.